This presentation will demonstrate the appropriate technique for the fixation of a combination of bilateral subcondylar fractures with a linear symphysial fracture of the mandible using the matrix mandible system. The combination of bilateral subcondylar fractures and a symphysial fracture occurs with rapid deceleration injuries where the force is applied to the chin. Open reduction and internal fixation of all three fractures will be performed in this exercise using two different fixation methods for the subcondylar fractures. The learning objectives of this presentation are the basic principles of the matrix mandible plate and screw system, the importance of establishing occlusion and adequately reducing the width of the mandible prior to fixation of the symphysial fracture, and the correct sequence of fracture fixation. The matrix mandible plate and screw system can be used for all mandibular trauma and reconstruction indications. All plates feature conical locking technology for a reliable screw-to-plate construct. The plates are available in thicknesses of 1.0 to 2.8 mm. In this exercise, a 4-hole 1.0 mm thick malleable trapezoidal plate will be applied to one subcondylar fracture. Two 4-hole 1.0 mm thick plates will be applied to the other subcondylar fracture, and a 6-hole 1.5 mm thick plate will be applied to the symphysial fracture. Locking and non-locking screws are available in diameters of 2.0 to 2.9 mm. In this exercise, 2.0 mm locking and non-locking screws will be used. One screwdriver blade fits all the screws. All of the screws can be used with all of the plates. All of the plates, screws and instruments are color-coded. This is the clinical situation. Preoperative X-rays are needed in two planes, usually a panoramic and a Towns view. CT scans are very helpful for these complex fractures. The combination of a symphysial fracture with subcondylar fractures creates the potential for widening of the mandible. This can be present as flaring of the angles and a posterior crossbite. In the clinical situation, loss of the airway secondary to posterior displacement of the tongue can occur. Treatment is aimed at reducing the increased width by open reduction and stable internal fixation. The standard approach for fractures of the symphysis region is intraoral. There are various approaches for the subcondylar fractures: retromandibular, submandibular, and intraoral. The treatment of bilateral subcondylar and symphysial fractures usually begins with the most anterior fracture component and ends with the most posterior one. The symphysial fracture is to be repaired with a 1.5 mm thick matrix mandible plate and 2.0 mm locking screws inserted bicortically. This plate is much stronger than a standard mini plate. The fixation of the subcondylar fractures is usually performed secondarily. The model must be prepared before the exercise may begin. To do this, the two condyles must be inserted into the rubber holders on either side of the skull. Before open reduction and stable internal fixation in the dentate patient can begin, the correct occlusion must be established. For this exercise, Ernst ligatures have been selected to hold the occlusion. However, it should be noted that many surgeons prefer MMF with arch bars because of the increased stability. The combination of fractures in this model causes widening of the mandible. Therefore, it is imperative to adequately reduce the width of the mandible prior to fixation of the symphysial fracture. For treatment of the symphysial fracture, the instruments needed are 2 reduction forceps with points, 2 bending pliers, a 1.5 drill sleeve with thread, a 1.5 mm drill bit, a depth gauge, and a self-holding screwdriver. The model requires 2 1.5 mm monocortical holes to be drilled at the superior border on either side of the fracture to help when placing the reduction forceps. In the clinical situation, care should be taken not to harm the tooth roots. The line connecting the holes should be perpendicular to the line of the fracture. The mandible halves are manipulated until anatomical reduction is achieved. The reduction is secured with the forceps. It may be necessary to place a second clamp across the mandibular dental arch to help reduce the width of the mandible. The 6-hole 1.5 mm thick matrix mandible plate will be applied to the inferior border of the mandible. The plate is contoured with the bending pliers. The plate is positioned a few millimeters superior to the inferior border. The plate holding forceps with ball tip can be used to maintain the position of the plate on the bone. The 1.5 drill sleeve is screwed into the plate hole closest to the fracture. A 1.5 mm drill bit is used to drill bicortically. The depth gauge is used to measure the length of the screw needed. The appropriate length 2.0 mm locking screw is inserted and tightened. A second screw is inserted on the other side of the fracture in the same way. If the plate holding forceps were used to hold the plate in place, it is now removed and the remaining plate holes are filled using locking screws. Both reduction forceps are removed. It must be confirmed that the reduction is adequate, that fixation is complete, and that no gap exists on the lingual aspect that would lead to occlusional disturbance and mandibular widening. The subcondylar fractures will now be treated. 2 bending pliers, a 1.5 mm drill bit with 6 mm stop, and a self-holding screwdriver are needed. The first subcondylar fracture is reduced into its proper position with the following steps. The MMF nearest the fracture is partially released. The distal fragment is pulled inferiorly with the reduction forceps. The fragments are aligned using a linear check gauze packer or another reduction instrument. The MMF is re-tightened. If arch bars were used for MMF, the use of elastics can facilitate the reduction. A 4-hole matrix mandible trapezoidal plate is adapted to the lateral surface of the mandibular ramus in the subcondylar region, assuring that 2 plate holes are above and 2 below the fracture. A 1.5 mm drill bit with 6 mm stop is used to drill monocortically through the most posterior superior hole of the plate into the condylar neck. A 2.0 mm non-locking screw, 6 mm in length, is inserted, but not fully tightened, until the final reduction and plate position are confirmed. Before inserting the second screw, the plate must be properly aligned so that all holes in the plate are located over sound bone. The plate can be rotated around the first screw until this is assured. A 6 mm long, 2.0 mm non-locking screw is inserted into the other plate hole superior to the fracture. The plate is used to manipulate the proximal fragment. It must be confirmed that the reduction is adequate before inserting the screws inferior to the fracture. The second subcondylar fracture will now be repaired. A 4-hole, 1.0 mm thick matrix mandible mini plate is adapted to the lateral surface of the mandibular ramus along the posterior border. The fragments are aligned using a linear check gauze packer or another reduction instrument. The 1.5 mm drill bit with 6 mm stop is used to drill monocortically through the plate hole superior to the fracture. A 6 mm long, 2.0 mm non-locking screw is inserted, but not fully tightened until the final reduction and plate position are confirmed. Before inserting the second screw, the plate must be properly aligned so that all holes in the plate are located over sound bone. The second screw is inserted into the most superior hole of the plate. The plate can be used as a handle to help reduce the condylar fragment. Once it has been properly reduced, a third screw is inserted just below the fracture line. A second 1.0 mm thick mini plate is applied to the bone, anterior to the first. It must be verified that the inferior plate holes are not located over the mandibular canal before inserting 2 screws superior to the fracture. The anterior plate is now used to manipulate the proximal fragment into the correct reduction. The correct reduction must be confirmed before a screw is inserted just inferior to the fracture. The remaining plate holes are filled. The MMF is released and the occlusion is checked. No post-operative MMF is needed, however it is recommended that the patient remains on a soft diet for 4 weeks. If an arch bar was used, it should remain on the mandible for 5 to 6 weeks. The result of the procedure can be seen in the clinical pictures. And the post-operative X-ray. This presentation has shown the appropriate technique for the fixation of a combination of bilateral subcondylar fractures with a linear symphysial fracture of the mandible using the matrix mandible system.